2 hours is not a lot of time to cover all of medical oncology because there are a lot of things going on here. And fortunately, a lot of good things are going on. But we'll see what we can cover and what we can talk about here. You know that cancer is a very common disease, and there are a lot of cases of it out there, about 500,000 deaths per year in the United States, about 1,500 per day, 1.4 million new cases if we exclude the non-invasive lesions, non-melanoma skin cancers. There's quite a few cancer cases out there. Is extremely costly to society. Direct medical costs are around $69 billion in 2004. And on top of that, there's about $120 billion of lost productivity. So in 2004, the estimate is cancer costs this country about $189 billion. So this is a very, very important illness. You've also seen all these statistics. Cancer is still rated the second leading cause of death in the United States. There's been some recent press about that it actually has passed cardiovascular disease as the #1 cause of death. But that's an artificial statistic because for some reason they decided to exclude deaths over age 85. I have no idea why you would do that. But if you do that, yes, cancer does pass heart disease. But if you look at all deaths, cancer still really is #2. Now, one of the things that is not very good here is if you look at the change in the cancer death rates or all death rates for various diseases over the years. And if we look at the death rate between 1950 in the blue and 2001 in the yellow, if we look at cardiovascular disease, there's been a huge improvement of 586 deaths per 100,000 down to 245, so essentially cut in half. Cerebrovascular disease also been cut down substantially. Pneumonia. Unfortunately, cancer has really not changed. Now, part of this doesn't necessarily mean that we're not doing a better job. People are surviving longer with cancer, but as people age, if they don't die of their heart disease, they now live long enough to develop cancer and are dying of that at a later age. And I will show you some data that suggests we are still doing a little bit better. If we look at the lifetime chance of developing cancer, it can be extremely high. If we look at overall for men from birth to death, there's roughly a 1 in 2%. 50% chance of developing cancer in your lifetime. For women, it's a 1 in 3 chance. For certain diseases, you're very familiar with the statistic of women have a roughly 1 in 7 or a 1 in 8 chance of developing breast cancer in lifetime. In prostate cancer, for men, roughly a 1 in 6 lifetime chance of developing it sometime. This does not necessarily mean you die from it, but a chance of developing it at some time in your life. But if we look at how we've done with treatment of various cancers, we look at 3 different time frames and look at a 5-year survival. In 1974 to 76, there's about a 50% overall 5-year survival for all cancers. That's improved to 63% by the late 90s. So we have made some difference. Now, how much of this is lead time bias is somewhat uncertain. How much of it actually more effective therapy is really uncertain as to which this is. If we look at certain types of cancers, though, unfortunately, things like lung has not changed at all, pancreas has not changed at all, but some have changed substantially, such as breast cancer from 75 to 87% 5-year survival, prostate, again, from 67 to 98% 5-year survival. So we are clearly doing better with some, others we're not doing such a good job with. What we do know is we clearly know that the risk for developing cancer is an interplay between the genes that you bring into the situation and your environment. So, for example, in those people with familial adenomatous polyposis who have the APC gene that they inherit, virtually 100% of these people will develop colon cancer by the time they're 40. So they come in with this huge, huge risk from their genes. As opposed to other people who bring in perfectly healthy genes and no genes that confers any risk to them, if they get exposed to enough radiation, for example, if you're around Chernobyl at the time, there's a very high chance that you're going to get cancer from the environment. And really, it's going to be an interplay between those two things, both some of the genes you bring into it as well as the environment. For example, in a syndrome known as hereditary non-polyposis colon cancer, about 80% of those people will eventually develop some cancer. So not all of them do, so it's probably some interplay between the genes you bring into it and the environment. For the BCRA1 and 2 mutations, an increased risk of both ovarian and breast cancer. The risk is somewhere between 30 and 80% of lifetime risk, but it's not 100%. So not everybody who has the gene gets it. And so there's some interplay between the environment and that. And as we learn more about the various genes that are around, there certainly are many metabolic genes that may process and detoxify carcinogens. There may be DNA repair enzymes present, hormonal metabolism enzymes that may influence your chance of getting cancer. So again, some interaction between the genes you bring into it and the environment that you're in. Now, what do we have for our medical treatments for cancer? Well, we have several of our standard things. Cytotoxic drugs, which we consider our conventional chemotherapy. These have been around a long time, and we still use these. They are still very effective. New ones are being developed, and they're working very well. We have hormone therapies that we can do, mostly hormone blocking things, where we try to remove or reduce hormones in certain situations for hormone-sensitive tumors. An up-and-coming field is immunotherapy, with things such as interferon, interleukin, or vaccine therapy is one of the newer areas that's coming here. And we're going to hear more and more about vaccines in the coming years. There are a few actually out and in use today. One of the bigger fields is also this so-called targeted therapy, where we're trying to target specific abnormalities present within malignant cells and target these things that promote growth or inhibit growth or induce apoptosis. And a few of these things are actually currently used today, and we'll talk a little about this. We also have what are called small molecules that, again, are signal transduction inhibitors that may be targeted specifically at cancer cells, as opposed to chemotherapy, which basically just tends to affect rapidly dividing cells, indiscriminate of which they are. We also have a whole series of other drugs that are being used now for palliation of cancer symptoms and for adjuvant therapy. Things such as bisphosphonates for people with bony metastases may be very helpful to decrease new bony metastases and other things, and we'll spend some time talking about that also. I do want to clarify a few terms that we use in oncology, because sometimes these can be very confusing. A few of these terms are fairly straightforward. If it's curative therapy, duh, the goal is cure. We'd like to have all of our therapy be that. We're not at that point at this time. But there are some other terms that are thrown around that oftentimes get confusing, and people who are not oncologists don't necessarily understand these terms very well. And one is the use of neoadjuvant therapy. Now, whenever we use adjuvant therapy, adjuvant is some type of additive therapy to whatever the primary therapy is. Now, primary therapy is for solid tumors most commonly an operation. Sometimes it's radiation therapy. But if we add something that helps the effect of that, we call it adjuvant. If we give it before the primary therapy, we call it neoadjuvant. So it's given before the primary therapy. For example, we often may do this in breast cancer, and somebody presents with a very large breast tumor. We may give them neoadjuvant chemotherapy to try and shrink the tumor, make the operation easier, and hopefully more successful. Most adjuvant therapy is given after the primary treatment, again, most commonly being surgery, but sometimes being radiation. This is designed to try and help prevent or delay a recurrence and increase the chance of cure. And then palliative treatments, again, is aimed not at treating the tumor itself, but treating the symptoms of the disease. And one of the things we have to keep in mind, if we are focusing on palliative treatment only, we have to make sure that the side effects of our treatment are not worse than than any benefit the person's going to get from that. So why do we talk about adjuvant chemotherapy? What's the rationale behind that? Because we're doing this a lot, and we're seeing it a lot more, and you'll see it more and more as things go on. Our rationale behind it is we know in people who have established cancer and advanced cancer, our chemotherapy seems to be the most effective when there's the least cancer present. So if somebody has a very large tumor burden, our chemotherapy works to a certain degree. If they have a smaller tumor burden, our chemotherapy works better. So the idea is that if we take somebody who has a chemosensitive tumor and is just at very high risk for recurrence, we know there must be some residual tumor hiding somewhere. It may be so little we can't see it, but there's a very small amount. So if we bring in chemotherapy at this time, can we increase their chance of curing because they have so little disease left behind? And in many situations, we can do that by improving survival rate as well as decreasing recurrence rates. And I'll show you some examples of what sort of results we can get with this in some very specific diseases. So that's the rationale behind that. We can also use adjuvant hormonal therapy. Of course, this only applies to hormonally sensitive tumors, most common ones being breast and prostate, but there are other diseases too. And again, The advantage of this, it's often less toxic than our chemotherapy, but it has its own side effects. In ER and PR positive breast cancer, no question, hormonal therapy decreases recurrence, improves survival, and an added benefit, it may decrease the development of new second primary tumors. Prostate is often used as a neoadjuvant. If somebody has a very large prostate with cancer involved, you may be able to shrink the prostate down before either operating on it or radiating it and decrease some of the toxicities of the primary therapy. The problem with adjuvant hormonal therapy, of course, it has side effects. All of our treatments have side effects to some degree or another. They may go through significant hormone withdrawal and all the downsides of that, things like deep venous thrombosis, increased risk of endometrial cancer, increased risk of cataracts are all seen with tamoxifen therapy. We have to be concerned about osteoporosis with some of our newer hormonal therapies, what are called the aromatase inhibitors, and we'll speak a little bit more about this. We may also do things like decrease people's libido because we are affecting their hormonal levels. And these are often very long-term therapies. We're talking 5 to 10 years of using these drugs. And so we may not even know some of the side effects of many of these at this time. So we are talking a very long-term therapy. Fortunately, it's relatively non-toxic and can be well tolerated. Radiation therapy can also be used in an adjuvant setting. And again, the problem with radiation therapy, it tends to be a local treatment. So if people do have a high risk of recurrence of a disease at a local site, adding some radiation to that site may decrease subsequent development of recurrence in that area. This is typically used in breast cancer, rectal carcinomas, prostate, lung, may be useful in pancreas, that's debated right now, but esophageal, head, neck. Also, it can improve survival in both breast and brain tumors, although it may not necessarily cure particularly brain tumors. Now, I want to try to explain a little bit about what is some of the concerns about adjuvant chemotherapy and some of the concepts behind it. And this is just an idealized schematic of what might be considered a randomized trial, where people in the green have a disease and are treated with just the primary therapy with no adjuvant treatment. And this is their risk of recurrence over time, survival without recurrence. So here at 4 years, there's about a 60% chance of being alive and disease-free 4 years after their primary therapy. If we have a treatment that has a response rate of roughly 20% in advanced disease, we might expect to see at this 4-year time frame about a 20% decrease in the risk of recurrence. Okay? The problem with this is that all these people are at the same stage. They all, as far as we can tell, have a relatively the same risk of recurrence. How do we choose the right people? Because if we treated 100% of people with this chemotherapy, those people who were alive and disease-free at 4 years with no signs of the disease went through the therapy for no good reason. Those people who got the therapy and had it recur anyway got it without any help. Those people who benefited is when we move somebody from this curve up to this curve. Okay? So we overtreat a lot of people because we don't have very good prognostic indicators for this. Now, if we develop more effective chemotherapy, the amount of benefit may well increase here. So if we have more effective treatment, we may see a bigger splay in the curve here, but we still may overtreat a large proportion of people. And again, I'll give you some examples as to what benefit we actually give for these people. But there are many people who will be overtreated, especially if we treat 100% of people with this. There's no question that adjuvant chemotherapy and adjuvant therapy helps in many situations. There's proven benefit from randomized trials that show in breast, colorectal, ovarian, anal, stomach, various sarcomas, and non-small cell lung cancer that there's clear survival benefit to giving adjuvant therapy after an operation. It looks like there's benefit in small cell lung cancer, head and neck cancers, some other sarcomas, bladder and esophageal cancer. So there's many different cancers where we clearly can improve the situation to some degree. Now, what about monoclonal antibody therapy? This is one of the up-and-coming fields of new treatments that we have. And there's many different forms of monoclonal antibodies we can have, whether it's pure murine, a pure mouse model, versus a chimeric part human, part mouse, whether it's a humanized antibody or a pure human antibody. And there are several that are actually out in everyday use now, including bevacizumab. These all have horrible names that I can't remember. Trastuzumab, which is also known as Herceptin, is very commonly used in breast cancer now, and there are several others out here that are available. The idea behind these is that what we're trying to do, we're trying to target something specific within the tumor cell that is abnormal. And many tumor cells overexpress something it's also normally present in many normal cells, but they may overexpress it. And this is just one example of a tumor that may overexpress epidermal growth factor receptor. Now, epidermal growth factor receptor is something that stimulates the cell to grow. And cancer cells may overexpress this, so they have many, many more copies of this than any normal cell. And what it does, it will go on and stimulate various processes within the cell that tells it to divide and go ahead and continue to proliferate. We have monoclonal antibodies that will target this now and will actually bind onto this, thereby inhibiting any stimulatory factor from interacting with this receptor and block this effect. And then by doing this, we may actually improve or slow down the cell's growth and improve survival with this. And this is actually a randomized trial of patients with advanced or metastatic colorectal carcinoma. And the people on the yellow here got standard chemotherapy with IFL. I won't bore you with the details of what IFL is because you really don't need to know that. But this group in the blue got both IFL as well as this monoclonal antibody. And they lived longer, median survival of 15 months versus 20 months. So it's not a huge benefit, but it clearly is a benefit. Fortunately, it's relatively non-toxic and very well tolerated. Unfortunately, it's extremely expensive. But it's clear that this sort of targeted biologic therapy is beginning to work, and you're going to see more and more of this as the time goes on, because we're trying to get more targeted with this. Now, this is just a schematic of a cell with many of the pathways that we know are disrupted. And everywhere you see red writing, we have a target, is something that we've targeted, and we have medications either in use today or in experimental therapies that are targeting these things. Again, I'm not going to bore you with the details, but there's a lot of these drugs being developed, and this is the future of medical oncology. So you hear about this more and more. A few of these are available today, and perhaps the most common example is Gleevec. I'm going to bet a lot of you have heard about this. This is a tyrosine kinase inhibitor, and it's used in chronic myelogenous leukemia and a fairly rare kind of stomach tumor known as gastrointestinal stromal tumor. These do overexpress this tyrosine kinase inhibitor known as c-KIT, and this blocks that signaling. Now, Gleevec happens to be what's called a small molecule. It just interferes with the receptor in a different way as opposed to what I showed you with monoclonal antibody. There's another one called Tarceva, which is, again, a different epidermal growth factor receptor inhibitor. It's now being shown to be effective in both pancreatic and non-small cell lung cancer. So these things are available and are coming down the pike. You'll see more and more of these. We are also developing many more supportive medical therapies. I've already mentioned bisphosphonates, either zoledronic acid, which is also known as Zometa, or pamidronate, also known as Iridia. And this is useful for several things. One, in people who have painful bony metastases, is often very helpful to decrease pain from those bony metastases. You tend to stabilize the bone, and it hurts less. Interestingly, in those people who have metastatic disease to the bones, particularly breast cancer, if you give them this prophylactically, it looks like it decreases the chance of developing any new bony metastases. So you may prevent some problems down the road. It doesn't cure people, but it certainly decreases skeletal complications, particularly in advanced breast cancer. We have other supportive drugs that we're coming up with. I'm sure you're all familiar with neutrophil growth factors. Filgastrum is the most commonly used one. There are several others out there. This allows us to do a couple things. One, it allows us to stimulate white cell growth so that we can often give higher doses of chemotherapy, which may be helpful. We may be able to give chemotherapy more frequently. Instead of every 3 weeks, maybe able to give it every 2 weeks in what we call a dose-dense fashion. So we're trying to hit the tumor more frequently, and that actually may lead to improved outcomes. You need to know that once a person is neutropenic, these drugs do not do very much good. Okay? And again, we'll talk about this a little bit more. There are some exceptions to that. But once they're actually low from having received chemotherapy, we often do not give it because it doesn't seem to help things. We also have growth factors for red cells, the erythropoietin. These are actually advertised on TV now. If you ever see, are you getting chemotherapy and you're tired? Ask your doctor about Procrit. So you can either be a professional cyclist and take that, or you can be a chemotherapy patient. But it is actually advertised on TV, direct to consumer. It really does help, decreases fatigue, decreases the need for transfusion, and we do use it a lot. It's a very helpful thing. There is a commercially available drug to try and help platelets. Unfortunately, it doesn't work very well. So we really don't have an effective one that we use here. So we don't have a good growth factor for that yet. So I'm going to switch gears here. I just wanted to do some general comments about where oncology is going and where it is right now, and then spend the rest of the time really talking about more specific cancers. And these are the ones we'll talk about in this session. We'll have others in the other session. But we'll start talking about colorectal cancer. Extremely common, 147,000 cases every year in the United States. Lifetime risk for an American dying of this disease on the order of 5 to 6%. Very high mortality from this, 57,000 deaths per year in the United States. And if we look at the American population, about 2 to 5% of the population may well die from this disease. 5 to 6% have a lifetime risk of getting it. 2 to 5% will actually die from this. Once people have metastatic disease, the median survival without any treatment is only 6 months, unfortunately. So it can be a very bad disease. We can actually improve this with some of our treatments, and I'll show you some data about that. You're probably also familiar with the fact that over the years, the distribution of colon cancer has changed. Where it used to be predominantly distal disease, particularly towards the rectosigmoid area, that has significantly decreased. Excuse me, let me go back here. That has decreased over time. We're not quite sure why that is. It may have partially to do with screening and finding earlier polyps in this area with our sigmoidoscopies and that, but it's clearly migrated some more towards the right-sided colon. What are the screening guidelines? These are the 2003 American Cancer Society guidelines. At age 50, everybody should have fecal occult blood testing and a flex sig with a double contrast barium enema every 5 years, or a colonoscopy every 10 years. Those are the two things. These have to be adjusted for moderate or high-risk individuals, and we'll talk about the risk factors in a minute. And in general, what we say when you moderate for a high-risk person, what we used to say is begin screening 10 years younger than the youngest first-degree affected relative. So if your father had colon cancer at age 42, you should start your screening at age 32. So take 10 years off that, because we need about 10 years lead time. So we look at kinetics of many different cancers. We may think it takes about 10 years to go from a single cell to a 1 centimeter lesion in many different types of cancers. So we're trying to look for plenty of lead time here. And that theme will come up in many different cancers. What are the risk factors for developing colon cancer? I'm sure you're familiar with many of these. Age, as we get older, we're more likely to have it. Diet, it's clear that the Western diet seems to increase the risk of it, and as a Westernized diet goes into more and more countries, the risk of colon cancer seems to go up in those areas. History of polyps, either in yourself or your family, may increase your risk. If you have a personal history of colon, ovarian, uterus, or breast cancer, or a family history of those same things may increase your risk for development of colon cancer. If you have a personal history of ulcerative colitis, certainly increase your risk of colon cancer. There are several varieties of familial colon cancer. One of the most commonly seen ones is, one of the most commonly talked about ones is familial adenomatous polyposis, but this only represents 1% or less of colon cancers. So it's really quite rare. We did mention this once before. And these people have hundreds or thousands of polyps throughout their colon. Even by age 20, they're starting to develop these. And if you see their colon, it's just carpeted with these tiny little polyps. And many of these people will develop cancer by the age of 20. And virtually 100% of these affected individuals will have cancer by the time they're 40. There is something known as Gardner syndrome that this may be associated with. Gardner syndrome is familial adenomatous polyposis, plus they get these benign tumors, the skin, soft tissue, and bone on top of that. The more common of the familial colon cancer syndromes is what's known as HNPCC, or hereditary non-polyposis colorectal cancer, also known as Lynch syndrome, named after Henry Lynch from Omaha, who actually described this. In this setting, there's actually very few polyps present in the colon. There may be, there may not be. Okay? Polyps are not a hallmark of this disease. But what is seen in these families is other cancers also: ovarian, stomach, small bowel, pancreas, kidney, uterus, and bile duct. And what we know is that these people have a problem with their mismatched repair enzymes. It's very common that when we replicate our DNA, our mechanisms often make mistakes and substitute it in an inappropriate base pair. Well, we have a series of enzymes that go in and find that and then repair it. These people have a defect in those repair enzymes. And what ends up happening, we end up finding what's called microsatellite instability in these tumors and in their normal tissues. And this is actually how we find this syndrome. We look for this microsatellite instability. But these people are at very high risk for developing any one of these number of tumors. Stage and treatment of colorectal cancer, we're going to go through this fairly quickly, but stage 1 tends to be limited to the mucosa or only into the muscularis. Treatment is surgical excision only. There's some question, well, with stage 1, there's no question, it's surgery only. With stage 2, where you're in through the bowel wall, but not yet to lymph nodes or to adjoining structures, should adjuvant chemotherapy help here? A lot of debate about that. I think the board question right now is no. You do not give adjuvant chemotherapy for stage 2 colon cancer. It's different for rectal, and we'll talk about that. Stage 3, however, is node-positive disease or invasion into an adjacent organ. Here, chemotherapy clearly decreases recurrence rate and improves survival. There's no question about that. So chemotherapy is clearly indicated here. Stage 4, or metastatic disease, is an unfortunate presentation for this. It can present at this. This, of course, is where you have metastatic disease to other organs. So for the vast majority of these people, they're unfortunately going to die of their disease. However, we have now begun to recognize there is some subset of people with metastatic disease, particularly if they have oligometastatic disease, very limited metastatic disease, a single hepatic lesion, a single lesion somewhere. They may do well with resection of that lesion, that metastatic site. Now, with that, out of a highly selected group of people, 5 to 10% will go on to 5 and 10-year disease-free survival if we do that. So it's a minority of patients, but it's an important minority that we need to pick up and we need to pay attention to. Whereas in the past, when we saw metastatic disease, we said, forget it, it's all over, you're going to die from this. It's true for many people. There's still some people we can help by either treating with chemotherapy and resection or resection primarily. Now, rectal cancer is a little bit different because the blood supply is different and there's much higher local recurrence rate. And in rectal cancer, for stage 2 and 3, we always recommend adjuvant chemotherapy associated with radiation therapy to the area. Because these have, just because of the anatomy, a much higher risk of local recurrence, so we always add that. Now, stage 1 did not need that. Stage 4 is a different story again. For adjuvant chemotherapy for colon cancer, for many, many years, we used 5-FU and leucovorin. And Mayo Clinic is one of the places that pioneered this. Well, Mayo Clinic has fortunately pioneered the new standard in this, which is known as FOLFOX. I won't bore you with the details of what that encompasses, but it stands for various chemotherapy drugs. It is clearly a new standard in adjuvant therapy for this, and we do much better. We also have a new drug called capecitabine, which is an oral equivalent of 5-FU. We've never had an oral 5-FU available. So for people who are not a good candidate for the more aggressive chemotherapies, it's an oral form of chemo, usually fairly well tolerated, can be done fairly easily. But we really don't use the old-fashioned 5-FU and leucovorin anymore. So it is an important new standard. If we look at how we've done against the treatment of stage 4 colorectal cancer over the years, we compare 1980 to 2005, we've made a huge advance. Whereas 1980, the median survival stage 4 disease was only 5%. In 2005, it really should be up to 20 to 30% 5-year survival. Again, comparing to best supportive care here. We've developed all these new drugs. Bevacizumab, again, is one of these monoclonal antibodies that we're now beginning to use. It's showing effect. Lots of different chemotherapy drugs. So we're clearly having a significant impact on this disease. Again, many are still not cured, but we're doing a much better job. Rectal cancer, as I mentioned, has a higher local recurrence rate, so in those we do treat with radiation combined with chemotherapy. We may, again, in this setting, use neoadjuvant chemotherapy to try and decrease the size of the tumor to make an operation more feasible and hopefully to make rectal sphincter sparing operation possible. Otherwise, these people do end up with a colostomy. The other thing you need to keep in mind about rectal cancer, it has a different pattern of recurrence, and it's mostly based on its venous drainage. The venous drainage here goes to the systemic circulation as opposed to the portal circulation. So here you're much more likely to see lung metastasis as opposed to liver, whereas colon almost always goes to the liver before it goes other places. Rectum may bypass the liver and go right to the lung. You have to be aware of late side effects of therapy, because as we're getting more and more survivors out there, you're going to see more and more late effects of therapy in general practice. Things like chronic proctitis from the radiation, maybe stenosis of their rectum, bladder injury, incontinence, impotence, rectal injuries. And these can be very devastating chronic problems for these people. So I'm going to leave colon cancer and move on to another very common kind of cancer, prostate cancer. Extremely common, 230,000 new cases each year in the United States. So it's right up there with breast cancer, which is about 220,000 new cases. It's the most common cancer in men if we exclude the non-invasive skin cancers. It leads to about 29,000 deaths in men. So it's still very important. It's only second only to lung cancer as cause of death in men. A very important disease. But you can look at those statistics. Many men who develop this will not die from this disease, but will die with this disease. It's important to try and sort out who those are. It's clear that there's a very steeply rising incidence after the age of 50. And so in many of these people, there are very high competing morbidity and mortalities. Okay? They may die of their heart disease. They may die of COPD, advanced dementia, and other things. And so the course of prostate cancer can be hugely variable. It can be extremely aggressive. It can be extremely indolent. It's very hard to predict. Some of the things that we do look for are what's called the Gleason score. And when you get a prostate biopsy, you see Gleason score. And the Gleason score can range from 2 to 10. 2 is a very well-differentiated disease. Those people often have very slow, chronic, indolent courses that don't bother them very much. 10 is a very bad sign. Those people tend to have a very aggressive disease. So the higher is worse. If we look at autopsy studies, what's the chance of men having prostate cancer? Men who die from any one of a number of diseases, not necessarily prostate cancer. At age 50, your chance of finding prostate cancer is only 29%. By the time you're 90, virtually 100% of men will have some degree of prostate cancer present in their body. Again, many times that wouldn't bother them, but it's a very, very high risk of doing that. The risk factors for prostate cancer, of course, being men is more likely than being women. I know breast cancer happens in men, but I've never heard of prostate cancer in women, so I think that's sexist for some reason. Age as you get older. If you have a family history of it, we have to be aware of that. Race is important. Blacks are much more likely than whites to get it, and Asians are the least likely to have this. It's unclear why that is. And blacks often have a more aggressive form of the disease. There's some question that dietary fats may play a role here. That's unsettled, and there's a lot of debate about that, but it may have some role. Other things that are somewhat unproven but controversial, cadmium exposure, smoking may increase risk. There's been a lot written in the past about people had a vasectomy may increase their risk. It's not clear that that's panning out. There's conflicting studies about that. One thing we do know, though, for sure, is that eunuchs do not get prostate cancer. So nobody's yet signed up for my prostate cancer prevention program for some reason. I don't know why that is, but it would actually probably, I think, be very helpful for society, probably decrease the crime rate, decrease risk of war. So it may be good on many fronts, but they don't want to do that. A couple words about you're familiar with screening for prostate cancer, about prostate-specific antigen. We'll go over the screening recommendations in just a minute. PSA is something that it is a protein made by both normal as well as neoplastic prostate epithelium. The level is proportional to the prostatic mass. So the bigger the BPH you have, the higher your PSA level. Now the problem is that PSA cannot differ between benign hypertrophy, infection, and cancer. There has been a lot written about PSA density and PSA velocity and all these different things. The bottom line is you can't tell the difference. There may be subtle differences between the two, but you really can't tell the difference between cancer and not based on the PSA value alone. It is extremely valuable for monitoring the course of the disease once cancer is diagnosed, but you can't rely on that alone. And one example is that people with very poorly differentiated cancers, the Gleason 10, may not make PSA because their tumor is so poorly differentiated it can no longer manufacture PSA. So those people often present with metastatic disease but a very low PSA, even though they have prostate cancer. So our current screening recommendations include digital rectal exam beginning at age 40 and over, adding a yearly PSA in there at age 50. Higher risk people such as African Americans, family history, should begin their annual PSA screening at age 40. Now, if you look at the various societies, though, there's very little agreement between all these things because there's really very little proven survival benefit based on these. Okay? So the different societies have different recommendations, and none of them agree. So I don't think this should be a board question because it still just remains too controversial. One of the key things that I think it needs to be communicated, though, is that as people get older, remember this is a disease of older men, once again, if a person has a comorbid illness where their life expectancy is under 10 years from that comorbid illness, there's not much point in screening for prostate cancer anymore. Because again, the disease may be relatively indolent and it maybe not be helpful to diagnose local prostate cancer in a 97-year-old with advanced dementia. It may not do them any good. So again, stop your PSA screening if their life expectancy drops below 10 years. The prognostic characteristics for prostate cancer, of course, stage, if it's prostate confined or local versus metastatic. The Gleason grade, the lower is better, 2 to 6 is much better than 7 to 10. Pre-treatment PSA value does have some prognostic significance. Those with higher levels do worse. Or conversely, some people with very low levels do very poorly too, because it's a very poorly differentiated disease. The primary treatment for prostate cancer is surgical, so we have to leave this in the hands of the urologist for the most part. Radical retropubic prostatectomy is done. Fortunately, Dr. I'm blanking his name, from Hopkins, has developed a nerve-sparing procedure that can decrease the risk of impotence and incontinence and rectal injury, but these still are risks to this operation, and I'll give you some statistics on that in a minute. There is still a 1 to 2% significant perioperative morbidity from this operation. It is a very big operation, and on the average, there's between 800 and 1,000 cc's of blood loss during this operation. So this is not a benign operation by any means. If we look at the chance of impotence in people undergoing a nerve-sparing operation, it's really dependent on the age of the patient as well as how good the surgeon is. So the better the surgeon, the more likely you are to maintain potency here. If you're in your 40s, there's about an 86% chance of maintaining potence. If you're in your 70s, it drops to 50% or less. So the older you are, the less likely you are to maintain potency at that age. Incontinence. Severe incontinence, fortunately, is only present in 1 to 2% of people who have a very good surgeon and good prognostic characteristics. But 7% still complain of frequent leakage, and up to 42% complain of occasional leakage, even in the best of series. So this is a lifelong problem. So again, if you're diagnosing somebody at age 50 or 60 who may live to be 85, they may have 25 years of wearing diapers or Depends. That's a significant impact on patients' life for a very long period of time. We have to pay attention because rectal injury do occur in this, and they may have rectal incontinence too. Radiation therapy works equally well to radical retropubic prostatectomy in terms of survival. There is a slightly higher risk of local recurrence if we treat with primary radiation, but it is a very effective form of therapy, so we tend to offer one or the other to most patients. We typically use external beam therapy, either conventional, tend to aim towards the prostate only. If they have more locally advanced disease, we may radiate the entire pelvis to try and get the lymph node bed involved in there too. There are some ways that we're trying to do to confine the radiation, so we aim the beam a little bit better and affect surrounding tissues a little bit less. So I just mentioned intensely modulated and 3D conformal, so we're just trying to do a better job with our radiation. There is another way to do radiation that's in brachytherapy, where you implant radioactive seeds throughout the prostate, and you literally put hundreds and hundreds of seeds into the prostate, and these stay with them forever. So whenever you do a pelvic x-ray, you see all these little white bullets in their prostate, and they stay there forever. There's a couple different ways to do it: low dose rate, high dose rate. Many people are not candidates for this, depends on the stage of the disease. Some people are very good candidates for it. But we often use radiation in people who are not a good operative candidate, people with bad heart disease, wouldn't tolerate a big operation, etc. But again, as I say, the survival is the same for radiation as it is for an operation. There may be a higher risk of biochemical recurrence, in other words, the PSA going back up sometime afterwards. So we use this for poor operative risks. Brachytherapy is really only used for people with very good risk prostate cancer only. Okay? We often may combine radiation therapy with hormonal therapy. This is a situation where we may do neoadjuvant hormonal therapy. If we shrink the prostate down, we decrease the size of the radiation field. It may spare the rectum from radiation injury. Side effects of radiation, very similar to side effects of the operation: incontinence, impotence, proctitis, and here we see secondary malignancies. And it may be as high as 1 in 125 people at 5 years and 1 in 70 men at 10 years. These include cancers of the rectum, bladder, and sarcomas within the radiation field. So we have to understand that's not a benign therapy. Now, once people have been diagnosed with prostate cancer and have undergone some form of definitive therapy for it, some form of curative therapy, we will monitor these people with PSA, and it can be a very effective way to monitor these people. And if their PSA goes up, we call these folks a biochemical recurrence. Then, of course, we'll look to see if we can find systemic disease. If they still have just localized disease, we may go in and either re-irradiate that area or try to resect that area if it's localized to the prostatic bed. But an important lesson we have to know here is that if we look at people who've had definitive therapy for their prostate cancer, either radiation therapy or prostatectomy, and get no further therapy, the median time between the first biochemical recurrence and the development of their first symptom from metastatic prostate cancer, the median time is 8 years. So again, look at the patient. If you have a 97-year-old who has a biochemical recurrence of their PSA after treatment for prostatic carcinoma, it's going to be 8 years before they're likely to develop any symptom from that metastatic disease. Their competing comorbidities may dictate their course, so we may just leave them alone. And the median time to death from metastatic prostate cancer is 13 years after the first biochemical recurrence. So again, pay attention to the whole patient and what's going on with their other problems. So really consider their comorbid conditions. For treatment of advanced prostate cancer, this is where the medical oncologists come in. Androgen deprivation, chemotherapy, and radiobiologic agents are the 3 modes we have to treat that. In men, you're aware that there's the 2 major sources of androgen. Testes make 95% of it. Some is made by the adrenal glands. So we can do a couple things. Orchiectomy. Orchiectomy is a very effective treatment for prostate cancer. It just removes 95% of the testosterone in your body. It can be very, very effective. See dramatic shrinkage with that. Again, many men are uncomfortable with the idea of doing that. So we can do chemical castration by using LHRH antagonists. We can also use estrogens. Estrogens work very well here. Be careful of the side effects of estrogen, including deep venous thrombosis, other things like that, gynecomastia, those things can occur. The LHRH antagonists, leuprolide or goserelin, are very effective. These are typically given as depot injections once every 3 or 4 months and can significantly drop your serum testosterone levels to very, very low. You have to be careful because when you give these, you will get a temporary increase in testosterone because you get a release of testosterone when you do this. So you may make a temporary flare of the disease. So if people have widespread metastatic disease, you don't want to do this by itself first because you may make their bony pain a lot worse. If they have an impending cord compression, you may complete that cord compression by stimulating further growth of the tumor because their testosterone will go up before it comes down. So if that's the case, we'll add an anti-androgen for about a month before we start the LHRH antagonist, and that will blunt that response. Speaking of which, we do have anti-androgens such as flutamide, bicalmate, and cypretone. These can be used alone or in conjunction with the LHRH antagonists. Androgen deprivation can lead to hot flashes, decreased libido, impotence, thromboembolic events, tumor flare, gynecomastia, diarrhea, other side effects. Chemotherapy is no longer just palliative in prostate cancer. We do know that docetaxel and prednisone actually improves survival in people with hormone-refractory metastatic prostate cancer. We do have other palliative chemotherapy can be used. We also have radioactive isotopes that can be injected intravenously, so people with widespread bony metastasis, these are bone-seeking isotopes that will go to the areas of the tumor and deliver their radiation there. You can get significant myelosuppression from that. I do want to quickly cover testicular cancer because this is a very important disease. The reason is it's highly curable even when metastatic. People who are at high risk for this include people who have cryptorchid testes. They're roughly 40-fold increased risk of having testicular cancer. People who have Klinefelter syndrome are also at risk for breast cancer. And we all recognize the most famous cancer survivor in the world here who's actually writing as we speak. There are 2 main categories for testicular cancer. It is important to know this because they're treated differently. There's seminomas, and then there's not seminomas. And there's several different flavors of non-seminomas. Seminomas make up about 40%, non-seminomas about 60%. You don't need to know the details of this, just think seminoma or not. Okay. Alpha-fetoprotein is a tumor marker made by many of these. It's made by the yolk sac, liver, gastrointestinal tract. This may be elevated in other diseases such as hepatomas, but it may be elevated in germ cell tumors too. It hangs around about a week, and that's important for watching for response, but I don't think you need to know that. Beta HCG is another tumor marker that's made by the placenta as well as syncytial trophoblasts, a great Scrabble word. It may be elevated in pregnancy, trophoblastic disease, and germ cell tumors. It doesn't hang around very long, so again, helpful for monitoring the course of the disease. Now, an important lesson here is in seminomas, only about 10% of seminomas will have a beta HCG elevated. Okay? So 90% of seminomas have no marker elevated. Alpha-fetoprotein is never, ever, ever found in seminomas, in pure seminomas. If an alpha-fetoprotein is elevated, it's a non-seminoma by definition, and you treat it as such. In non-seminomas, 85% have one or the other elevated. So 15% will have no tumor marker, 85% will have one of them elevated, and we can use that for monitoring. A couple things about the management of testicular cancer, seminoma particularly. Always an inguinal orchiectomy. One of the rules of life is never let anybody violate your scrotum, and that's valuable for lots of things. But you never biopsy through the scrotum because you'll seed a different lymphatic bed. So everything has to be done through the inguinal canal and resected that way. If they have local disease, we often will give some radiation because these are exquisitely sensitive to radiation and very high cure rate here. I'm going to skip over that. More advanced stage disease, again, inguinal orchiectomy, maybe some chemotherapy, very high cure rate. For non-seminomas, these are less radiation sensitive. They are still radiation sensitive, but they're not as sensitive. They have early stage disease. Just removing it and watching only is a very reasonable thing to do, very high cure rate. The problem is we need very close surveillance of these people. And if they have a recurrence, we can often cure them with chemotherapy or an operation. The problem is this happens in young men, and young men are dirt, and they don't come back for follow-up. They disappear. So sometimes when we have them, we'll go ahead and do a retroperitoneal lymph node dissection, because that may help decrease the risk of their recurrence. But that's a very big operation, not without its own side effects. If they're reliable for follow-up, it's fine to follow them with CT scans and markers on close basis. For more advanced stage disease, a platinum-based chemotherapy, again, very high cure rates, and they can do very well with this. I'm going to sort of skip bladder cancer. It's important out there, but we won't have enough time to do this. May present with some penis hematuria. Smokers are at increased risk of this. Also, schistosomiasis gives a very rare form of squamous cell. Kidney cancer is interesting in that it may present with very strange syndromes such as polycythemia, fever, polymyalgia rheumatica, or a weird thing where they just get these abnormal liver function tests, and you remove the tumor. Even though there's no cancer metastatic to the liver, they have all these abnormal liver function tests. You take out the tumor and their liver functions go back to normal. Very strange. I want to say a couple things about carcinoma in primary because this is important. If we look at all cancers, about 2 to 4% of the time we don't know where the cancer came from. In academic medical centers, that number may be as high as 10% because of the referral bias pattern. It's more common as you get older. It's more common in men than women. We don't know why it happens, but and we actually pre-mortem very rarely find the primary lesion in these settings. Unfortunately, it portends a very poor prognosis, but there is a subset that's curative, and we have to pay attention to that subset. It's most commonly adenocarcinomas, 30 to 60%. It may be so poorly differentiated you can't tell what kind of a cancer it is. Some squamous cells and some variety of other things are in there also. If it's above the diaphragm, it's most likely a lung origin, okay? If it's below the diaphragm, it's most likely pancreas or liver biliary primary, if we ever find it. A couple exceptions here. If we find it in an axilla in a woman, we treat it as breast cancer, because what we have to do is we have to look for things that are treatable and curable. So in an axillary presentation of an adenocarcinoma in primary, we assume it's breast cancer because that's a potentially curable disease. Anywhere else that an adenocarcinoma in an axilla in a woman came from is not curable. So we treat it as if it's the curable thing. When you do see this, we don't want to waste time or money on it necessarily. We ask our pathologists to do a lot, but don't spend a lot of time doing a lot of scans trying to find where it came from because it may not matter. It may not matter. And these people do fairly poorly. If they have disseminated disease, their survival is extremely poor. If they have limited disease and a good performance status, they do a little bit better, but still the survivals are very poor here. If they have truly just localized disease, there's some subset we can cure with that. And this is, again, where like an axillary presentation for a female is important. I know I ran over some there, but I'll stop, and we'll make it up on the next talk.
Our first question involves an otherwise healthy 32-year-old man who presents to you with questions about screening tests for colon cancer. He reports that his two older sisters developed colon cancers at age 40 and 42. His mother had both colon cancer at age 40 and subsequently developed endometrial cancer at age 45. And a maternal aunt had breast cancer at a young age. He notes that there was never any history of colon polyps in any family member. You recommend he undergo A, annual fecal occult blood testing, B, colonoscopy now and every 1 to 2 years, colonoscopy with random biopsies to look for inflammatory bowel disease, and if not present, then he should follow routine screening recommendations for average risk Americans. Prophylactic colectomy, reassurance only since no polyps were found in family members. The correct answer is B, colonoscopy now and every 1 to 2 years. You all did very well on that. I don't think we need to. Should we have a little comment?
Yes, just a couple words here. One, prophylactic colectomy, we would only do that if we found to have the gene present. Okay, so not all people have it. And this history is one for hereditary non-polyposis colon cancer with the various other cancers that are present there at the early age. Again, very high risk, and with the first degree affected relatives at age 40 and 42, you'd start his screening in the 30s. And again, we would test him for the gene before we'd think about a prophylactic colectomy. If he does have the gene, then you would definitely consider that as a therapy down the road. That is a reasonable thing. But a prophylactic colectomy is not a benign procedure either.
A 65-year-old male presents with a 2-month history of rectal bleeding and bloating with nausea and vomiting and a 25-pound weight loss. Examination reveals a thin, cachectic male with no jaundice. His liver is enlarged 6 centimeters below the right costal margin. On rectal exam, there is a firm mass which is bloody and obstructing the lumen. Imaging studies confirm diffuse metastatic disease in the liver. A biopsy of the liver is consistent with metastatic rectal cancer. What is the most appropriate next step in the evaluation or management of this patient? A, radiofrequency ablation of the liver mets. B, chemotherapy. C, radiation with concurrent chemotherapy. D, surgical consultation for diverting colostomy. E, hepatic infusion of FUDR. D, surgical consultation for diverting colostomy.
A little bit of confusion here, you can see. In this person, the key thing is that he's obstructed and he's having nausea and vomiting. And presumably that's from the obstruction process. So you need to get him in better performance status before we can start treating him with some type of systemic therapy. He unfortunately has incurable disease, but we can improve his survival with systemic therapy. We really can't give him systemic therapy until we can make him feel a little bit better. So we'd probably do a diverting colostomy just to get him better so he can get chemotherapy. And by doing that, I think we would help him out. Radiation is actually not indicated in this setting. For most rectal cancer, we do radiation with curative intent. Once it's metastatic, there's really no role for that, partly because the liver really doesn't like to be irradiated for that. So.
A previously healthy 27-year-old man presents with abdominal pain. Evaluation eventually leads to a CT scan of the abdomen that shows extensive retroperitoneal adenopathy and multiple small pulmonary lesions. He is a non-smoker and has no significant secondhand smoke exposure. Biopsy of a lymph node and a lung nodule reveals poorly differentiated neoplasm, primary site uncertain. Which of the following statements is false? A normal alpha-fetoprotein and beta-HCG levels effectively rules out presence of a germ cell neoplasm. Ultrasound of the testes is required. He has a potentially curable disease. Systemic chemotherapy should be offered. A history of Klinefelter syndrome or cryptorchidism places him at an increased risk for this disease. And the correct answer is A, a normal alpha-fetoprotein and beta-HCG effectively rules out presence of a germ cell tumor.
Yeah, that's very important to keep in mind because, again, as we said, 90% of pure seminomas do not have any serum marker. 15% of non-seminomas will have normal serum markers, so you still can have that. And a young, healthy gentleman, widespread disease, we always think of things that are still curable because the things that may do this would be lymphomas, but again, the lymph node biopsy would show whether it's lymphoma or not, as opposed to a carcinoma. If there's a carcinoma, we treat it as a germ cell because it is still potentially highly curable. And again, Lance Armstrong is a great example of that. And so the other things that we do treat those with systemic chemotherapy. It may be curable. We would look an ultrasound of the testes because if you can find the primary that is helpful, we will eventually remove that testicle. And then certainly Klinefelters and cryptorchidism increase his risk for that disease.
A 76-year-old male with a history of coronary artery disease and left leg DVTs was referred to the emergency room because of back pain and lower extremity weakness. He has a history of localized prostate carcinoma treated 2 years ago with primary radiation therapy. The physical exam reveals a somewhat anxious gentleman with left lower extremity weakness but normal sphincter tone. His PSA is elevated at 400. Previously, after radiation therapy, his PSA was normal. An MRI demonstrates epidural extension at L2. After dexamethasone, he is improved and pain-free. What is the most appropriate next step in the management of this patient? Combination cytotoxic chemotherapy, DES or estrogen, orchiectomy, LHRH alone, bisphosphonates. And the correct answer is C, orchiectomy. Could we get some comments on letter E?
Yeah. Bisphosphonates are a very good thing to use for people with painful bony metastases. It does really decrease the pain from those. So it is helpful in that setting. The concerns here is that prostate cancer, if he has not had systemic therapy or hormonal therapy, is very sensitive to hormonal manipulation. So we want to do something to decrease his serum testosterone levels and help with that. And there's a couple ways we can do that. Estrogens do work in that regard and work very effectively, and DES is very cheap and easy to use. The contraindication here is this is a gentleman who had a prior history of DVTs. So that would further increase his risk of DVTs, so you wouldn't want to use it here. LHRH antagonists alone, I agree, you would not want to use because of the concern that may make the tumor flare. He has what appears to be epidural extension of a tumor in the L2 region. You may worsen his epidural disease, cause a cord compression by adding LHRH antagonists alone. So you want to do something to decrease his serum androgen levels. And again, the only choice here would be orchiectomy that would be appropriate because of the concern of the flare with that. So I think bisphosphonates are a good idea down the road. Right now, to treat his cancer is probably the most effective thing.
Is there any chemotherapy that
Chemotherapy chemotherapy can be used in this setting. Again, the hormonal therapies are much more benign as well as much more effective in this setting. So we would reserve chemotherapy for hormone refractory disease only. The chemotherapy works, but not that well, and hormone therapy is easier and works better.
A 42-year-old female patient comes to the emergency room with symptoms of small bowel obstruction. Laparotomy reveals a 3 by 3 centimeter mass in the mesenteric root, which has caused invagination of the small bowel. The mass is resected together with part of the affected small bowel. Pathology reveals the presence of lymph node metastasis of an undifferentiated adenocarcinoma. In this patient, the most likely primary site of this adenocarcinoma is pancreatic cancer, anal cancer, cervical cancer, melanoma, small cell lung cancer. And the correct answer is A. 83% said pancreatic cancer. Could you comment on cervical cancer?
It's a bit of a trick question. Pancreatic cancer is the only one up there that's an adenocarcinoma. Anal and cervical tend to be squamous cell. Melanoma is melanoma, and small cell is a small blue cell tumor. There are extraordinarily rare adenocarcinomas of the cervix, but that's hen's teeth. But really, it's sort of a trick question in that regard. Also, whenever we do see an adenocarcinoma in a primary below the diaphragm, the most likely site is either pancreas or hepatobiliary tree primary.
The board loves those sorts of things. Read carefully. An 80-year-old male with a history of hormone refractory prostate carcinoma presents with pain in his lumbar back. It is not responsive to over-the-counter pain medications. An MRI shows extensive bony metastases with no cord compression. His bowel and bladder function are preserved. On examination, he is a weak, elderly gentleman with a performance status of 3. His cancer has progressed through prior radiation therapy, steroid therapy, and radionucleotide therapy. He has contacted hospice and wishes to enroll. What is the most appropriate next step in the management of this patient? A, avoid opioids because of the possible addiction and constipation. Recommend that he not enroll in hospice because there are proven treatments that could significantly improve his overall survival. B or C, prescribe Demerol shots every 6 hours. D, initiate a PRN pain medication with a narcotic and begin a bowel and bladder regimen. E, initiate a plan to use scheduled narcotics to control the pain and then convert to a long-acting pain regimen. And the correct answer is E, initiate a plan to use scheduled narcotics to control the pain and then convert to a long-acting pain regimen. And you all did quite well with that. Perhaps we could just comment on D.
PRN payment.
PRN.
First of all, I'm very glad that nobody said Demerol, and thank you. We've been working really hard to get people to stop using Demerol, and so I applaud you for that. That's very good. The key thing is that this guy, it has pain that's not going to go away any time in the near future, so he's going to need long-term pain control. So we're going to want a scheduled drug in there. We don't want to just PRN unless we would have something that would take his pain away. That's the only time you use a PRN medication. You need to have a scheduled plan, but it has to be a plan that's adjustable. So if he's not getting pain relief, you can go up on it or more frequent, whatever, but it has to be a scheduled dose of drugs. Again, remember, whenever you start the opioids too, remember to start a bowel regimen. Constipation's not fun.
Our final question, a 65-year-old, otherwise healthy male patient undergoes surgery for T3N1 sigmoid cancer. Preoperative CT scans demonstrate a large solitary lesion in the right lobe of the liver, which is not resectable due to its size. No other site of metastasis can be identified. Intraoperatively, the diagnosis of a liver metastasis is confirmed by biopsy. What is the most appropriate statement regarding his overall prognosis? His expected median overall survival is in the range of 6 to 12 months. Any treatment will always be palliative. Spontaneous regression of metastases is a common phenomenon in colon cancer. With neoadjuvant chemotherapy followed by resection of the liver mets, the patient has a chance for cure. Since the presence of a liver mets indicates as asystemic spread of tumor cells, surgical approaches to remove the liver lesion are inappropriate regardless of its size. And the correct answer is D, with neoadjuvant chemotherapy followed by resection of the liver metastasis, the patient has a chance for cure. 61% of you got that right. We will get some comments on the other answers.
Yeah, a couple things. Remember I said there is a subgroup of people with limited metastatic disease who can do well. It's only about 5 to 10% of a highly selected group of limited metastatic disease. But this is a guy with a good performance status, otherwise healthy prior to this time, has a large lesion in his liver. Our chemotherapy is getting more effective at shrinking cancer, so we may be able to shrink it into a resectable size. So we would say that even if he had metastatic disease, median survival for metastatic disease for all people with colon cancer is now on the order of 24 months for all comers with that. So I think A would be inappropriate at this time no matter what. B, it's not necessarily palliative because, again, there's a very small but a real chance of cure here. Spontaneous remissions just don't happen. Spontaneous remissions have been reported in all cancers, but they're very, very rare in anything. The thing they're most commonly associated with is renal cell. Even in that setting, they're very uncommon. You cannot count on that happening. And so I think what we tend to do is try and treat him systemically, try and shrink that, make it resectable, because there's a 5 to 10% chance he could be actually cured of his disease with that. Small but real.